Thank you. Thank you. I would like to give a lecture about, I think, the easiest one compared with the previous lecture. Yeah, the lecture from Dr. Ramani and Dr. Nijasi a bit complicated. And then this is the simplest one, which is ultrasound carotid. And then firstly, I would like to let you know, we need to know what is the B mode, color power Doppler, pulse wave Doppler, and how to identify the artery by using the ultrasound carotid. And then how to identify the plaques, and then we'll come to the discussion as well as the conclusion. So I will give you the kind of the case studies after all the information that I will give it to you later. And this is the extracranial ultrasound. The function is to assess what is the cervical portion of the carotid and vertebral arteries. Because by using the ultrasound carotid, it will give us the valuable information about the amount of the disease present, kind of plaques could be severe, moderate, or and also the presence of the plaques could be heterogeneous, homogeneous, isoechoic plaque as well. And then how to localize hemodynamic effects, which is moderate, severe stenosis, and then what kind of atherosclerotic plaques. And then by using the extracranial ultrasound, it will guide us what kind of management, especially for stroke disease or acute stroke ischemic stroke. And for the indication, what is indication by using the ultrasound carotid? First, we can determine what kind of intima media thickening, usually because of the hypertension disease. And after that, ICA stenosis. Also, we can determine stenting after CA or carotid atherectomy. We can monitoring the patient as well. And then we can determine what is the ICA occlusion, mobile thrombus, and then we can see the motility of the thrombus as well. And then also for subclavian syndrome, and also we can see non-dominant vertebral artery and dominant vertebral artery too, because sometimes the non-dominant vertebral artery can give, like kind of severe stenosis, but actually this is not stenosis, but this is because of the non-dominant VA. So that's why by using the extracranial, we can measure the diameter of vertebral artery and also the carotid dissection. And here's the B mode. So B mode, you can see here, the B mode, you can see a CCA, and then this is the bifurcation. And if you see the branches, so you will know this is the ECA. If let's say there is no branches, for sure this is ICA. And after that, this is the cross-sectional view, but you can see by using, this is longitudinal view, but you can see the cross-sectional view first. And then by using the cross-sectional view, you can see the ICA and ECA. And then from the cross-sectional view, you go to longitudinal view. So from here, I can show it to you later during the demo. And then after B mode, power Doppler, and then you put the color, so you can see the red depends on the color scheme, but usually we do the red one for the artery, and then the blue for the vein. And then after color Doppler, you just try to fulfill everything. So if there is no stenosis, then you can see everything. But if there is plaque, so usually they will fulfill the color. If let's say the plaques, there is a intraplaque hemorrhage, the color itself will fulfill the plaques itself. I can show it to you from the video that I will give it to you later. And then after that, you need to put the pulse wave. The pulse wave, if let's say from the CCA first, you need to follow the pulse wave Doppler from the CCA, and then if you see mixed high resistance and low resistance, usually this must be CCA, because CCA before divert to ICA and ECA, they will have the mixed flow first, and then if let's say you see high resistance flow, so this is confirmed ECA, because ECA will not go to the brain. So that's why they will ECA will have the high resistance flow. And then you can determine what is the ICA and ECA. You can use the temporal tabbing. So if let's say the temporal tabbing is positive, so usually this is ECA. This is how to determine which one ACA, which one ICA. And this is the identification of the artery. First, CCA, you can start from the base of the clavicula, and then you just follow the through up to submandibular. And then if you tilt to the, usually sometimes depends on the patient, could be medium to the medial or the to the lateral, usually the medial, usually like ICA, and the medial usually to the lateral, usually ECA. But like I said, don't use those kind of demarcation, because some of the patient could be different. Better you just see if there is a branch, must be ACA. If there is no branch, usually ICA. If high flow velocity, high resistance flow, must be ECA. If low resistance flow must be ICA. This is the baseline that you need to remember, the demarcation. And this is the I show it to you how to find the ECA, ICA, and will be demo. I will show it to you also during the demonstration later. Okay, and this is the Spencer curve, which is you need to remember. So the decreased diameter or the smaller diameter, so the flow velocity will be decreased too. So this is the most important Spencer curve. Whether if you want to take neurosonography exam with ASN or WFN, they will gonna ask you this Spencer curve cerebral hemodynamics. But you need to remember some certain, so around depth, around diameter, around 70, 60. So the flow velocity will be decreased. And you need to remember sometimes, because the small diameters, the flow velocity also will be increased a little bit. So be careful with the grading, for especially for the high for the higher diameter reduction. So that's why you need to see the pattern. If you see high flow velocity, usually really below before the stenosis. If let's say dampen, then usually after the stenosis. So that's why you need to recognize what kind of flow velocity. This is the vertebral artery. Vertebral artery, you just need to tilt a little bit medial from the clavicula. Then you see the both transverse process. If you see the both transverse process, surely this is vertebral artery. And then you need to measure the lumen, the diameter of vertebral artery. See, this is the key to know whether this is dominant or non-dominant vertebral artery. And then this is plaques. How to recognize the plaques? Because you need to know the size, morphology, as well as echogenicity. So the size could usually focal or along the wall. And for the morphology, usually homogeneous, heterogeneous, and mixture. And how do we know this is homogeneous and heterogeneous? You need to use the muscle as the baseline. If the plaques, see, this is the muscle. If let's say the plaques similar in terms of the echogenicity, so usually this is homo. But if let's say you see the calcified, or also you see the same similar with the muscle, so that means this is mixture. But if you see only white calcified, so that means hypercalcification. So will be hyper, okay? So homo, iso, and hyper, you need to determine. If let's say normal, the muscle is your landmark, okay? So if you see the calcification, so that's mean hyper. If you say both, that means mixture, okay? And ulcerated, like I said, if you put the color Doppler, so because there is, like kind of tear inside the plaque, so the color will be fulfilled through the plaque itself. Here, this is the example. This is the example of high flow velocity or carotid stenosis. So you can see the flow velocity around 157.2, and in the systolic 40.9, like Prof. Nijasti told us before. This is also exactly the same like TCD. Basically, for stenosis, the stenosis will be the same with TCD. This is a high example for carotid stenosis. This is the intraocular hemorrhage. You see there is a tear. So if you put a color flow, the color Doppler, they will fulfill inside the darker side. Inside you see the plaques right here. This is the like kind of very dark. This is like intraocular hemorrhage. Okay. This is also thrombus, example of thrombus. You see, they're moving more immobile. Yeah, this is organized thrombus. So so that means how do we know this is already quite established? You can see already become brighter than it was used to be. So if let's say you can see the thrombus only like kind of mobile, usually this is still acute, but later by the time goes by, it will become brighter. This is the example of subclavian syndrome. This is how to memorize it. You just remember the bunny waveform. If you see the bunny waveform on the vertebral, so this is clearly subclavian still syndrome. Okay, so if you try to confirm by using cuff maneuver, and it will reverse completely. So this is really a real subclavian still syndrome. Okay, then I go to the case 1. 55 years old women presented with chronic hypertension, and then the medication she didn't take regularly, and her ultrasounds carotid show like this. You can see the intima media thickening. Okay. And case number 2, 65 years old man have atrial fibrillation. He developed also left hemiparesis, and the brain CT scan show large infarct in the right hemisphere. And then the ultrasound also showed here mobile organized thrombus because of the heart. Okay, and by using the ultrasound power Doppler, we can see the quite high resistance flow. This is clearly ICO occlusion, but could be ICO occlusion intracranial, because like I said, if you see the high resistance flow, usually the occlusion just in front of you. But if you see the dampened or if you see the blunted waveform, the occlusion behind you. This is case number 3, 58-year-old man, they presented with vertigo, also have a left limb ataxia, and then brain CT scan shows a left salvar infection. And from the ultrasound carotid, I found high resistance flow too. So that means if high resistance flow, there will be occlusion in front of the artery. Okay. So case number 4, 70 years old women, pre-CABG, also develop hypercholesterolemia and diabetes. This patient referred for screening carotid stenosis, and ultrasound carotid also showed there is massive, plaques, and then almost occluded, but luckily this plaque also still got like kind of space, and then the blood flow still going through the brain. So that's why the patient still looks normal. And the vertebral artery also, there is a plaque in this patient as well. And from the carotid ultrasound, you see very high flow velocity around 206. of the EZA, and the bulb also around 239. And this is the CT angio. So basically, this patient, we did stenting. We did the stenting, and then the patient already went well. So in conclusion, extracranial and vertebral arteries are easily studied by using ultrasound. We also combine B-mode, power Doppler, color Doppler, pulse wave Doppler to detect the disease. And there are many indications for performing ultrasound, not only for stroke, but we also consider dissection, subclavian still. But we must adopt to uniform and detailed technique to ensure the proper study. Thank you very much.